The next speaker is Loya Al-Haberi from the University of Cincinnati Medical Center, who is going to present a case report on using an iliac branch and the prosthesis to salvage a kidney transplant in a symptomatic aortic aneurysm. Please.
Good afternoon, everyone. I would like to thank the committee for giving me the chance to present our work. My name is Loya Al-Haberi. I'm the fourth-year vascular surgery resident at the University of Cincinnati. I'll be presenting about a novel use of an IBE device. I have no disclosures. Our gentleman is an 84-year-old with an end-stage renal disease, status post-kidney transplant 20 years ago. Also had a AAA repaired with an EVAR 10 years ago. He presented to our facility with a symptomatic aorto-iliac aneurysm. He was hemodynamically stable at the time with elevated creatinine. This is his pre-op CT scan, and as you can see, this is the previously placed EVAR with expansion of his AAA up to 10 centimeters, and at the same time, an interval development of a right common iliac artery aneurysm up to 5 centimeters, involving that origin of the transplanted kidney artery. This is also his coronal images, so you can appreciate the takeoff of that transplanted kidney artery. We discussed multiple options with this patient. He appreciated the complexity of his anatomy, but he wished to proceed with something that would save his kidneys. So we proceeded with the following approach. This is our pre-intervention angio. We had access from the left brachial and the right femoral. As you can see, the internal, external, and the transplanted kidney artery. We then deployed an emplaster plug into that right internal. We then placed the IBE device from the IBSE groin with the contralateral gate facing laterally towards the kidney. We then came from the arm and cannulated that kidney artery and bridged that with the IBE with a balloon expandable stent graft. We then extended the other limb of the IBE into the external and deployed an iliac limb. This is our completion angiogram, which shows patent flow to the kidney and to the right lower extremity, and at the same time, successful exclusion of his aorto-iliac segment. He did well post-operatively. It was uneventful, and he came back at 1 year for follow-up with a non-contrasted CT scan and a duplex. This is his non-contrasted CT scan, which shows decreased size of his aortic sac and iliac aneurysmal sac, and at the same time, the duplex showed that it was negative for endoleaks with patent flow to the transplanted kidney and to the right lower extremity. I think the IBE device is a viable option in treating those complex anatomy aorto-iliac aneurysms in the setting of a kidney transplant. Thank you.
Thank you very much for a challenging case. I have one question. Do you know by any chance how much contrast was used, and would you consider doing this under CO2 angiography?
We used minimal contrast. His creatinine was 1.6. I think we completed the whole procedure with less than 40 to 60, I believe, cc's.
Ross Milner, Chicago. I just wanted to say, as many people in this audience know, I like doing complex aneurysm disease. I also like creative solutions. This is A+. I love this one. You need to try to get this published. This is a very cool case. Very nicely done.
Thank you.
Dr. Smeds?
Yeah, hi, I'm Matt Smeds from St. Louis. I don't really have a question. I'm just following up on Ross's statement there. Hopefully everybody's going to submit their papers to JVSCIT.
Shameless plug. That's great. Thank you very much.